Okay. Hey guys, Dr. Dawn Ewing here with the IABDM, and tonight we are talking about myofunctional therapy again. It's a tandem off of what we learned the other evening. So many hygienists are looking for other things to do in the office besides just working with their patients, and of course we found out that myofunctional therapists get to work by conference calls and still get to see some of their patients. So this might light a fire under you to want to take some classes. I'd like to introduce Barbara Green. Barbara is not new to myofunctional therapy. Matter of fact, I didn't even know that myofunctional therapy was around as long as she's been doing it. So I would like to take it over to Barbara, and Barbara, just tell us how you got started in it and let's go from there.
All right, I see I've already made a mistake. I have IAPMD, but it's IABDM.
Yes, it is.
I apologize for that. So, well, I am Barbara Green, and I have been in myofunctional therapy since 1971. And it has been an incredible journey. It has been an incredible career. And I see it as a God function because so many lives have been changed by my working with children and adults who need myofunctional therapy. So I love it. I am passionate about it. And I got started in it by mistake, actually. So first of all, I would love to share with you some of the people that I want to honor. My parents, first of all, because they were always positive, happy people and very service oriented. And that to me is how I've lived my life and has made a big difference for me. Viola Fryman, the cranial osteopath, saved my life in 1971. I was in severe TMJ dysfunction for 2.5 years, was in horrible pain 24/7. And she literally, by adjusting the bones of the skull and my body, got me totally free of pain. And I thought I had died on her table because I suddenly did not have any pain and my hands dropped down by my side. And I thought, oh, thank you, God, I'm dead, because the pain was gone. And then I brought my hands back up to my chest and went, oh my gosh, I am not dead and the pain is gone. So Viola Fryman has also saved a lot of the lives of my children and adults that have come to me, as well as other cranial osteopaths throughout my life. And then Daniel Garliner, Roy Langer, and Richard Barrett, who taught me myofunctional therapy. And I went to study myofunctional therapy because we had a patient who needed something. And we had no idea until an orthodontist sent her back to us and said, well, somebody's got to get rid of this tongue thrust. And we said, tongue what? So I went back to study at the Institute of Myofunctional Therapy. And as I'm sitting there and they're describing everything that I should look for and treat as a myofunctional therapist, I realized, oh my gosh, that's what I do. This is the problem that I have. So guess who was my first patient? Me. And then William Hang and John Yu, who totally changed my life by introducing me to orthotropics, which takes a child from the ages of 6 to 13 and totally builds their face and their mouth correctly. And by the time they're around an age where most orthodontists start work, they have big, beautiful faces and mouths. And Brian Hockel in Walnut Creek, who does beautiful orthotropics and other work and shares patients with me. Patrick McEwen, because he so beautifully teaches Buteyko breathing, which is a wonderful thing to know about and learn about. Kathleen Carson, who did my 3rd full mouth reconstruction after I had jaw surgery 5 years ago and did a beautiful job and gave me a gorgeous smile. So that's very nice. And then Felix Liao and Dr. Edmund Liam, both of them have influenced me over the years because they believe so much in myofunctional therapy and have helped so many people with their broad expanse of viewpoint of dentistry. And then lately, Soroush Zaghi with his philosophy about tongue tie and research. And then my dearest, dearest friend, Joy Moeller and Licia Coccini Pasquet, who have been my friends forever, and we have taught together forever. And just, it's nice to honor people. And so they are part of my being. And here's a little photo gallery for you. Licia Coccini is in the middle. Joy Moeller is down in the middle pictures. And that's Joy and I on our trip to Italy. Patrick McEwen is at the bottom. And over on the far right is William Hang. And then John Mew and his son, Michael Mew. And this is me. And I won the first Florence Nightingale Award at the AAMS meeting about 3 years ago. So that was very exciting. So why? I would like an answer to this. Why are there so many difficult cases now? I thought maybe it's because I was just getting older and I'm looking at therapy differently. But no, Joy calls me all the time. Where are these patients coming from? It just seems like there are so many more patients, even children, who are so much more difficult and so much more involved than they have ever been and need so much more treatment and attention, not just from myofunctional therapy, but from a whole team of us, it seems like. So where does it come from? Well, babies that are not diagnosed with tongue tie and have birth trauma, children then suffer the results of having that tongue tie and being fed incorrectly with bottles, with resultant allergies, congestion issues, mouth breathing, poor posture, poor sleep patterns, and then the soft diets. They're not chewing enough and they have poor development of their facial muscles, and they end up with narrow arches and poor bite development. And then we have orthodontic relapse and the result of 4 bicuspid extraction cases and surgical relapse. And then they're seeing doctor after doctor without success at correcting their problems and often adding new problems to deal with. And they're spending thousands of dollars without success. So, and then there's the many poor habits that people have. So let's talk a little bit about this. Here's a patient who has birth trauma. She was crying, but the doctor wasn't there yet. So he was on his way, so he told him to push her back into the birth canal, and then she became oxygen deprived. And so she ended up with a brain malfunction. She has a horrendous tongue thrust, as you can see, and her bite is so screwed up because of the tongue thrust. And of course, she sucks 2 fingers, and that adds to the problem of training her muscles to work the wrong way. Plus, she sits with her mouth open, and she was very congested the day that I saw her. Here's a baby with a tongue tie, and look at the tongue itself here, and you'll see how the sides of the tongue lateralize, and the back and middle of the tongue are totally depressed. This is a picture of the same baby 1 day after the release of the tongue tie. And look at this beautiful tongue posturing where the back of the tongue is now elevated as it should be, and the tip of the tongue is down, protecting the breast from the mandibular pad. And it's extraordinary, the difference. And of course, this baby was having trouble nursing. And 1 day later, she's fine. So it's very exciting that that can happen. And then children suffering from undiagnosed orofacial muscle dysfunction, end up with drooling, like here. They're mouth breathers. All of these cases show mouth breathing. They have poor resting tongue postures, and they develop long face syndromes and usually allergies. Now, the good news is what I have found over the years is once you correct the mouth breathing and you get the nose working again, so these are all things that we do as myofunctional therapists. And I want to also say kudos to Sue and Andrea yesterday for their wonderful presentation. It was very well done, or the day before, and very well done. And I enjoyed listening to them. Then they have soft diets, so there's not enough real chewing. They take too big a bite. They don't chew their food enough, even what they put in their mouth. And so they end up with these underdeveloped arches. So everything is too narrow. Everything is the palate going higher. And a lot of times, like in this picture, they have a crossbite. The upper arch doesn't even match correctly with the lower arch. And they end up with these long, flat faces. See the allergy rings under the eyes, and they're mouth breathers. They get sick a lot. They have a lot of colds. They catch the flu. So it's really so important that these patients are diagnosed and treated. And then we have the tongue tie as they get older. Here's a boy that he had everything wrong with him except enlarged tonsils. He had headaches every day, stomach aches every day, poor head, neck, body posture, speech problems. They had dropped him from the program at school. And he had orthodontic problems developing, and he was a mess. Sick a lot, 24/7 allergies, couldn't breathe through his nose. And look at this, that nobody diagnosed after 4 years of speech even. And this is a very serious tongue tie. This is just after the tongue tie was released, but it took me almost a month to get him to be able to actually hold his tongue against the top of his mouth. So you have to retrain any tongue tie release. They should have myofunctional therapy exercises prior to the release and then directly after the release to train the tongue to work a whole new way. It has no programming of how to work correctly. And then these are pictures of an anterior, more anterior attachment. And then this picture represents a patient who has the lingual frenum, a severe lingual frenum. And then here's the surgical procedure that was done. And this is before, when they tried to point their tongue, they ended up with a little heart shape with their tongue. But right after the surgery, they're able to point their tongue. So it's very exciting what can be accomplished with the release of the tongue tie. Then we look at poor posture, and we have to work with their head, neck, body posture. How could you retrain the muscles of his mouth and expect the muscles to work correctly when he has this severe head posture and body posture problem? And then I was at a meeting recently, and look at this bottom picture where this woman is sitting at the meeting, and she looks just like he does. And she's struggling to breathe. She probably has sleep apnea. I don't know because I didn't talk with her. But it's amazing how many people, even if they have pretty good regular posture, look at their head posture, because they tend to sit a lot of the day with their head to one side or the other. And then we look at how they sleep, because you have to retrain them how to sleep. If you don't, then as they sleep, they're promoting their own problem. So stomach sleeping is not at all acceptable. So we try to get everybody on their back. Occasionally you can't do that if they've had back surgeries, or I know with sleep apnea, they more recommend sleeping on the side. And I just threw these little animals in to show you that most animals are intelligent and they sleep on their back. And so if you look at this, the bottom pictures here, this is a special pillow that I actually have made for my patients. It's a little smaller than what you order online. Online, it's called the Face Saver pillow, but it's a little too thick for my liking. So I have them make the pillows a little smaller. So I have a number 4 pillow for the little kids, and that's what I use, actually. I guess I consider myself a little kid. And then if they sleep on their sides, you don't want any pressure on the face. So you want to be sure that they only have the pillow on their ear and up the side of their head, and no hands under the face, ever, or fists or arms. No hands or face under the pillow and under the face either. So you don't want that. And if possible, with their knees supported. Now, anyone who is a stomach sleeper, you're going to have to support their knees for at least a couple weeks or more, because they cannot sleep on their back comfortably. They feel like they are projected off of the bed. And once they use the pillow under their knees for a couple of weeks, their back muscles readjust, and then they're much more comfortable sleeping on their back. And eventually they'll come in and say, you know, I tried to sleep on my stomach and it is horrible. So they literally retrain themselves out of that. I love early development orthodontics that's called orthotropics. And these are just a picture of some of the appliances that they use, which are totally different than in normal orthodontics. But what they end up with after they have treated them during their growth time between the ages of 6 and 10 or 11 or 12, it depends on the child and their development. And they end up with these gorgeous, big, beautiful arches and room for their tongue. Oh my gosh, lots of room for their tongue. And usually I don't think you'd ever have to worry about these kids getting sleep apnea or having snoring issues. And they develop beautiful profiles and big round faces. It's just lovely. These are some of the other treatment modalities that people that refer to me, I work with. The ELF, this is an example of an ELF appliance in the mouth. And this is a Crozat down here on the other bottom side. And a Crozat is a lot like the ELF. The ELF was designed kind of as like a spin-off of the Crozat. And there's all different designs of the ELF appliance depending on where they are in treatment. But here's a person who's had the ELF. So this is the beginning picture and then the final picture. And Derek Nordstrom is basically the person who teaches the ELF appliance. On the bottom here is the DNA appliance, which is, it has certain springs in it that vibrate and helps to move the teeth. So here's an appliance in the mouth of one of my patients who was doing a DNA appliance, and that's Dr. David Singh's appliance. Now, this is a new type of work called the AGA, and AGGA, and a lot of orthodontists are liking it, and some general dentists are using it also. And here's one of my patients that it shows her when she started, and this is, she's still not done. So this after picture isn't even totally complete yet, but look at the difference in her face. It's really exciting. So you know, there's a lot of general dentists as well as orthodontists who believe in a more holistic approach to orthodontics and use some of these appliances. I use cranial osteopathy because it did save my life and it has made a difference in many of my patients. This young boy, his head was run over by a car. He ran out of a restaurant when he was 6 years old and ran into the car, bounced over the hood and then back under the wheel. And he went from a student and everybody loved him and he was just the best child to a child who was horrible. Nobody liked him. He was angry all the time. He was getting poor grades. And he was in my church, and I asked if I could see him because he started mouth breathing after the accident. But I didn't see that that was really his problem. I felt that it was the cranial. See, here's before and after cranial. And remember, they're adjusting the bones of the skull and the body out of stressful working patterns. And so here's his before head posture and the shoulders being out of alignment, whereas after he's in alignment. And this is, and I can't remember his last name. His name is Sean, and I apologize, I can't remember his last name, but he's in Pasadena, California, and he's treating a patient. So I just thought I'd put in a picture of that. Orthodontic relapse is, of course, something that we see all the time also, because if no one is diagnosing the tongue thrust and all these pressures, you're going to see orthodontic relapse in all shapes and forms. Here's a posterior relapse because they have a lateral tongue thrust. And the lateral tongue thrusts are the hardest to treat, but they are treatable. And then when you see, like yesterday, they were showing the ridges and scalloping on the tongue. Well, we get rid of those ridges and scalloping once we retrain the tongue, and it's functioning inside the top of the mouth without suction and without spreading into the teeth. So it's very exciting because when you get a significant tongue ridge especially, it literally can turn into cancer. And I had a patient whose tongue was turning into cancer, and we were able to get it so perfect that you couldn't even see the ridge anymore on the sides of her tongue. So that's really exciting when you can do things like that. Here's a patient that I am seeing. It's a 4 bicuspid extraction case, and it's relapsed. And now she has so little room for her tongue. She's in pain. She's absolutely miserable. So I get concerned when they're taking out teeth instead of making the mouth bigger and allowing a patient to have all of their teeth. We should even have wisdom teeth. And at a conference I went to one time, the university had done research on concussion. And what they found was when you take out the wisdom teeth, the body is more prone to concussion. And those third molars, they aren't really there for eating. They're there as an impact point for the bite when they have a concussion, so that it absorbs some of the pressure that would have gone to the brain. So when you take out the wisdom teeth, now there's no cushion there. So we're getting a lot more concussions because we're so routinely taking out wisdom teeth, which I think is very sad, instead of making the mouth bigger. So here's a surgical relapse case that I saw after the fact. She had had ortho and then surgery. And look at this tongue thrust that she has, and she's a mouth breather. So it's so logical to me that she would relapse, but not to them. And so we did myofunctional therapy, and she elected to have surgery again. But I heard from her sister, whose child I was seeing, and she said that the second surgery was successful. So that's exciting. This bottom case is someone who had surgery twice already, and they have recommended a third orthognathic surgery, but no one had diagnosed that he has a tongue tie and, of course, a severe tongue thrust. So it's so important that we diagnose these cases properly. Now, talk about habits. I am a huge proponent of habits, and you have to get rid of habits. You can do the best myofunctional therapy in the whole world and get them totally retrained. They're eating correctly, drinking correctly, sleeping correctly. They always have their tongue up, their mouth is closed. But if you don't get rid of these habits, they're going to relapse. And maybe not, because maybe they have just a slight habit that they only do occasionally. But basically, it is a major point of relapse because most patients have more than one habit. They might have 6 or 7 or 8 habits. But look at these habits that they have. Here's cheek biting. This is lip biting. And this is side lip biting. Then we have lip sucking in these 2 cases at the bottom. And here's a person who they suck their lip upward, and then you are overdeveloping the mentalis muscle. Then we have problems with their jaw placement. Here's a little girl who juts her jaw forward all the time. So she has an underdeveloped maxilla. Her body is saying, my jaw cannot be back in that position all the time. I have to get some release somehow. And so she juts her jaw forward. So she needs to have her whole maxilla developed and move forward so that she doesn't have to jut her jaw forward. And here's someone who holds her jaw off to the side all the time. And another person who pushes her jaw forward and pushes her lip forward. Here's another side angle. If you look at their smiles many times, they'll duplicate a habit. They'll either shift their jaw or they'll shift their tongue into the pattern that they have as a deviation. And then we have facial mannerisms. Oh my God, how many facial mannerisms can you take pictures of? Well, I didn't have any trouble finding some today. And here's a whole variety. This young man actually had about 7 or 8 different mannerisms. And here's a variety of different ones that you see patients do when they're thinking, when they are expressing themselves, or when they're angry, or when they're nervous, then the facial mannerisms come about. The other big habit that's a total no-no is leaning. Oh my God, how many people lean? And here's a variety of leaning. Now this one on the bottom with her fist, this is the most dangerous for the jaw joints, but any leaning is bad. And when they're leaning, they're pushing their cheek into their teeth. So you can't bite and swallow correctly all the time that they're leaning. And they're pushing their cheek into their teeth. So they develop cheek habits. They can actually develop open bites posteriorly because of their leaning. And anytime that they're leaning, they're putting abnormal pressure on the jaw joints. Anytime that they're leaning, they have poor head, neck, body posture. So leaning is such a no-no. It just is so rampant in almost every patient that you see. Other habits would be pen biting, nail biting, pipe biting, even how they hold a musical instrument. This woman developed oral dyskinesia because she had a right unilateral swallowing pattern and she held her violin with stress under her left side. And so because of if she had had a left unilateral tongue thrust, she would have been better off. But because it went to the right side, she was totally out of balance all the time. And she played it every day, many hours a day, and loved to play at their church. So we had to actually get her to use a front type of violin, viola, so that she could get the pressure off of her face and so that we could get control of her oral dyskinesia. And then this is a patient that I see. She's an actress and a singer and a dancer, but she pushes air into her cheeks because she feels like her lips are too much against her teeth all the time. So she's actually one of my current patients and is doing fabulous. Now here's some other things that I didn't have pictures of, and it reminded me I need to take some pictures of these new habits. Head forward while texting is a biggie. Head forward while playing video games is a biggie. Poor ergonomic posturing while they work at the computer, arms are too high, the screens are too high often. They end up with back pain, neck pain, and compromise their posture. Poor eating habits are huge. They take too big a bite, they chew with their mouth open, then they don't chew long enough, and then they swallow air when they drink and eat and swallow. So they also usually have gas or burping or hiccups or stomach aches or all of the above. And fortunately, when you teach them how to eat and drink correctly, that usually goes away, which is very exciting. Then the oral piercings. I refuse to do therapy on patients who have oral piercings. The tongue cannot learn to work correctly with them. So unfortunately, that's just my philosophy, because I know I can't accomplish what I need to accomplish. So the other thing that I have had new experience with, because this has only been on the market now for 6 months, is the stem cell patch. But I'm having some luck with it, with myself. And the reason I'm using it is because I have severe ear ringing 24/7, severe. And I've had it gradually getting worse and worse and worse since 1971. And I wanted to see if this is something that could stop my tinnitus. It has stopped the secondary noise. I still have the severe ringing, but I used to get like a Morse code tapping, and I used to get a roaring sound, and I used to get other sounds. So it is actually helping. So I'm somewhat encouraged about this. You wear the patch, it's just a little round patch, and you wear it 12 hours to stimulate. And in the patch are organic crystals that hold a patented light frequency. Then the heat of the body causes that to emit from our skin, the heat of our skin causes that light frequency to emit something that activates the patch to elevate the GHK-Cu copper peptides. That activates stem cell production. And it has the unique ability of turning into whatever cell our body seems to need to repair. Then you take the patch off for 12 hours for healing to take place. And I'm seeing some amazing changes in my skin, and it's pretty amazing to see. It takes away wrinkles and makes you look younger. Ooh, oh my goodness, how many people are going to be interested in it just for that? But my thing is for pain and inflammation, because I have back issues and knee issues, for more energy, for mental clarity, wound healing. This is another area of it that I'm interested in for my patients, because I have 2 patients right now who've had major radiation of their throat due to some cancer. And then they develop scar tissue. And the stem cell patches are seeming to be incredible at reducing the scar tissue and even getting rid of it completely. So that's another thing. And it has a lot of enhanced sports performance and recovery benefits. So if you have stem cells, once you're at the age of 50, your stem cells decrease and you no longer are producing them. So when you do the X39, you're either producing new stem cells, or your ones that you do have, they're regenerating them. So it's something to think about, and there's a possibility. I've had it help my patients with pain, TMJ pain, and back pain. So I'm really starting to recommend it and use it with my patients just to see if I can't help them overcome some of the serious things that they come in with. So the question is, where do we go from here? Well, recognition, recognition, recognition. So all the pictures that I just showed you, you have to look, and just like we're being taught with sleep apnea, we need to realize that we've got to ask the right questions. If we don't ask the right questions, we don't necessarily get the right answers. And I'm not convinced that sleep studies are as accurate as they think they are, because it is, to me, I couldn't sleep when I was there. And, you know, you're so wired up. And of course, I have to go to the bathroom so many times at night, and then they have to unwire you and then wire you back up. But regardless, sleep apnea is serious. And there's so many children now who have terribly, terribly restless sleep, and they snore. In fact, when I missed my lecture last night, which I sincerely apologize for because I'm not that kind of person, I was doing a consultation on 2 children in China who, there are 8 children in the family, and 7 of them have problems. And so the mother is actually going to buy, I have a DVD training kit that it's a 4.5-day course, and it teaches you how to learn how to do myofunctional therapy. And she's going to buy the DVD, and then I'm going to treat one of the children so that she can actually watch me go through this process with the child. And then she's going to treat the other 6 children. And so I'll send her the necessary therapy kits for the other children also. So it's very exciting. And we've got to really recognize where these things come from. And so if you're seeing an OSA patient, it isn't just OSA that you're treating. And I don't like a lot of the things that are being used for OSA because they limit the, they move the lower jaw forward like the appliances. And now you've got a problem with the masseter, pterygoid muscles, and temporalis muscles that are so important to the bite and correct function of the tongue and swallow. So almost, I would say, any OSA patient needs myofunctional therapy because we see the symptoms of it early. In the therapy, we're working to teach the uvula and soft palate area how to work, how to pull up and drop back into place. Whereas in sleep apnea, it can just fall back. In sleep apnea, the tongue falls back. But you get a patient sleeping correctly and having their tongue correct during the day across the top of their mouth, you've influenced greatly the sleep apnea. But you also have to look at tonsils and adenoids, because if they are large, they need to get them out of there. I have a patient right now that I'm fighting to get them to take out the tonsils. Another one of my patients, an adult, she finally listened to me, and she started seeing changes, but during the time that we were doing her therapy. And so she finally had her tonsils removed, and what a difference. The people, when she went back to work, said, "Oh my gosh, you look so much better and you sound so much better," because her speech was very, very compromised due to her low forward tongue position. And Sue referred to that yesterday. You can't make good L, T, and D sounds to the spot, and S sounds to the ridge, and G, K, and C sounds with the back of the tongue, which needs to elevate if your tongue is working incorrectly. So CH and J sounds are often compromised, SH sounds are often compromised, until the tongue realizes, oh my gosh, that's what I need to do to talk correctly. And all of a sudden, their speech is so much clearer. And if they still have a problem, then I send them to a speech pathologist to just work on the speech part of it. But it's amazing what the body will do once it learns what it is supposed to do at rest, during swallowing, during eating, during drinking, during sleeping. And you're getting that head, neck, body posture up instead of the head extension forward. You move your head forward like that, you're moving your tongue out of its normal range of movement. So you have to have a questionnaire that asks questions. And I love to train staff because as a front office person, you can sit there watching them do all these things in the waiting room. And so they're mouth breathing, or they're always, doing something with their nose, or they're doing some of their nail biting habit, or their various lip sucking habits and things. And how nice that a front office person can cue you in that, whoa, we have a problem here. And also your assistant should understand what to look for, because they don't always answer questions. I used to have a questionnaire on my website where they could sign up for the virtual therapy. So most of my therapy is virtual now. I have offices, but I get patients from all over the world. So most of my patients are virtual patients now. And yes, it's been wonderful that I was able to do my work sitting in front of my computer and still earning my money. Oh my gosh, it was really wonderful. So the things that we, where do we go from here? We have to support each other. And it's not just that I want you to refer for myofunctional therapy. I want you to understand how myofunctional therapy is going to impact everything else that you do. Your periodontal scores will improve. Your need for periodontal surgeries will diminish or completely disappear in many of your patients. And then they'll be able to wear their dentures or their partials, or you put in a bridge and they say it doesn't fit, it doesn't work right. So a lot of the problem areas that you have, they build up more plaque. And so then they get more tartar, their cleanings are more difficult. It doesn't take Carrie very long to clean my teeth because I don't build up the tartar like a person who pulls their saliva forward. So there's so many things that we can help each other with. If in referring for cranial osteopathy, or maybe chiropractic, or treatment of the bite. A lot of my patients recently have had 4-bite extractions. Now they're unhappy. They don't have room for their tongue. They've realized what their problem is. They found me online. And so your websites are very important with this. And now we're trying to find people that could help them to change their bite. Sometimes surgery is the only answer. It was for me, but that is not what a lot of people want. So if we can help them find other people to refer to, that helps you if you're a dentist, or even medical doctors, or the cranial osteopaths, or the chiropractors. More research needs to be done so that medical profession is more open to being able to recognize and refer for myofunctional therapy. They just don't understand a lot of these things. They're coming around more because of Dr. Gouline from Stanford, but that's only, they're sort of coming around. So it's, more research does need to be done, and thanks to Mark Moeller and all of his work with the AOMT and the AAMS, and his wonderful connection to the Brazilians who have done the majority of the research that we do have. But now a lot of the universities are starting to get on board with doing research programs. And so that's exciting. That's very exciting. So you might want to know how to contact me. I am very accessible. I live alone, and boy, even this COVID-19 time alone has kind of gotten to me, but at least I'm available. And you can go to my website at www.tonguethrust.com. And yes, I do get some weird emails because of my tongue thrust name, but that's okay. Because when people are told they have this problem, they don't say, I want you to see a myofunctional therapist or an orofacial myologist or an oral blah, 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 okay? They say you have a tongue thrust. So what are they going to key in is tongue thrust. And that's why I did my website and my email that way. And my phone number, 805-452-4302. My email is kind of easy to remember. It's just barbara@tonguethrust.com. And I do virtual therapy, so you can refer to me from anywhere in the world. I'd be happy to send you cards if you want them. And my costs are, I've tried to keep my costs down so that I can be more accessible for people. And I charge $150 for my consultation. It usually is 90 minutes or 2 hours. I charge $100 for the therapy kit, but then I charge by the visits. So it's $280 for every 4 consecutive visits. And my visits are 60 minutes long because sometimes the appointment takes 30 minutes, sometimes it takes 45 minutes, sometimes it definitely takes an hour, and sometimes we run out of time in an hour. So it allows me to treat the patient as completely as I need to. And what you need to realize, and I didn't put this on here, but we're only talking about a 3 to 5 month window. So in that short a period of time, all the things I've been talking about, I can get under control and show them a new way to function. And that is very, very exciting. So if the case is more complicated, like suppose I have to stop thumb sucking or tongue sucking or both, and they have a lot of habits. So then it's going to take more like the 4-month period, and occasionally it's 5 months. A lot of people don't do their exercises. That affects their success. They miss visits. That affects their success. Like today, I had 4 cancellations, and they had to move their appointment to next week. So when that happens, it just takes a little longer. But to me, changing a person's life in 4 to 5 months is awesome. Now, I then see them less frequently, and we've cut way back on their exercises, or they're not doing any. And I see them in a month or 2 months. And I try to keep seeing them for another, if possible, 6 to 8 months that way, just to be sure that they're habituated. If they're not habituated, I have failed, they have failed. They have to do this all the time without thinking about it. They don't sit down at a meal and think, okay, now I have to take a small bite, I have to chew with my mouth closed, I have to chew on both sides equally, I have to chew it 10 or 20 or 30 times, depending on the food, and then I have to gather it and swallow it. Well, who wants to have to do that every time they eat? But that's what they do to train themselves, and then it becomes automatic. And that's the exciting part. So I have offices in Ventura and Santa Barbara, California. I don't teach anymore because I don't travel as well as I used to, but I teach through my DVD. And my DVD is on my website. And right now there's a special for therapy on my website. So I'm not going to tell you how much it is. You'll have to look at my website. And the DVD is $675. And that includes the kit, It also includes a beautiful pitch book with all kinds of wonderful pictures of anatomy and the x-rays of the posterior airway and things like that. And dialogue, I teach you what to say with the pictures. And then you get a therapy kit for yourself and a therapy kit for your first patient. So that all is included in the DVD, and you can buy it either hard copy or streaming. So I think that's probably all that you need to know, other than if you want to ask me questions.
Barbara, I have questions.
Okay.
Dawn Ewing here. This DVD that you have, that's a kit. You go through that program. Is there a certification that's recognized?
No, it does not have a certification. The only people who have a certification right now is the IAOM. And I have their certification. But the problem is, if you ever leave the IAOM for any reason, you lose your certification. And that, to me, is unacceptable. So nobody else, the AAM or the AOMT, they have some sort of certification that they're working on, and I'm not sure where they're at with that. But what my goal has always been, we need a 2 or 3 year college program in myofunctional therapy, in orofacial myology. We need licensure. And so if we have the college program and the licensure, then it would solve all the problems. But right now, generally you have hygienist or speech pathologist, sometimes physical therapist, and sometimes an RN who might go into this type of work.
And I'm interested. I'd love to pitch an idea for you if we got a group of hygienists together, which I could imagine we would be able to do through the academy, if we could create some kind of a certification through the academy like we do for biological hygienists and assistants and dentists. If you would be willing to lead that in a distance learning, and we have predetermined times and work our way through the kit. Right. And that way maybe we could get a bulk price on, maybe we get 10 of us together and do Zoom meetings like this. Would you be open to something like that?
Yeah, the DVD is actually a course. So there's diagnostics, there's live patients being treated, and then it's a week-by-week progression. This is
how long does that course take?
Well, there's 18 CDs, and it just depends on how. It was a 4.5-day course that I professionally filmed. And so it just depends on how much time they have to sit down and look at the CDs. But I totally believe that myofunctional therapy has to be in a sequential program. I know some therapists who just kind of like, oh, well, they need this for the back of the tongue, or they need this for this. No, all of my patients go through the exact same program, but modified depending on their needs. Like right now, I've had a slew of patients, oh my goodness, that they could not use the middle and back of their tongue. So you can't do the normal program for probably 3 weeks or so. You pull in exercises that specifically work on strengthening the back of the tongue or on lateral flaring. And then you go back through the whole program so that they're learning step by step by step. And then the muscles can handle it. They can't handle just smattering of things and get the bigger picture. So I'm a very sequential type of therapist.
Yeah, I like that.
But again, it only takes, as I said, sometimes as little as 3 months. So my program is based on 12 weeks. Then at 12 weeks, we reevaluate everything and see where they're still weak. Then we work on those things. Then when we have those things corrected, now we should be able to have habituation. And that's your goal, obviously. And it should work the rest of their lives. I've only had a person in a car accident that we had to regroup and go back through her program, and a little boy who had severe emotional trauma. So there are things that can interfere, like the COVID-19 is getting to all of us. You know, it's just, sometimes those things are such overloads that it impairs their ability to stay with the program, or that they just go back to what they used to know. But I've never had anyone totally regress. So that's good news.
Wow, that's amazing. I am so happy that this worked out tonight. I think it really is a ton of information. I'd love for us to be able to do this through the Academy, and because we can do some kind of a certification, I bet that once this kind of hits the information world out there, that we're going to have a lot of people who would be interested in doing that. So I'm going to fire off an email to you right after this meeting. And what we're going to do is, does anybody that's on this evening have any questions? If so, you have to unmute yourself.
Yeah.
Okay, I put the contact information up here for the stem cell patch. Do you happen to know, Barbara, is that an MLM?
It is a network marketing business. And so you can, if they go to www.startx39.com, they can see a video, and there's testimonials and various things about that. So they can, you know, buy through someone who's in the company, or they can buy through the company.
Okay.
So what it in itself is a business. And I went in it strictly for my tinnitus, and hopefully it will help that. It's helped several other things for me already, but including my brown spots that you get when you get older, lightening up. So that was really exciting. But in fact, with the COVID-19, they have been in touch with the creator of this, because it is antiviral, and the hospitals and various people were contacting the company to try to figure out how he does this, you know, because it's a patented process. And it's only been on the market 6 months. It's pretty amazing the results that people have gotten already. So, you know, I'm always open to new things, and I think we all have to stay that way as dentists, as hygienists, and all of us.
Well, thank you again. We're going to go ahead and conclude the meeting so that we can get the recording up, and I'll be in touch with you just as soon as it comes through, which again will be about 20 minutes. And then we'll go from there. Thank you again, Barbara.